Thank you. The next speaker is Professor Lorenza Rimassa, who is a medical oncologist at the Humanitas Research Hospital, and she will give us an overview about the situation of cholangiocarcinoma in Italy.
Thank you, Chiara, once again. Good afternoon, and thank you again for the kind invitation. I will be talking about the situation in Italy. These are my disclosures, and this is my outline. I'll try to give you some numbers in terms of incidence, prevalence, and so on in Italy, and you will see that we have some issues. I will be talking about the APIC, that is the Association of Italian Patients with a Cholangiocarcinoma. We are lucky that we have a patient advocacy group that is very active in Italy. What we can do and what is reimbursed, and what we did, or what we are doing in terms of academic research based on what we can offer patients in Italy, and some conclusions and open issues. This is a book that is published every year, or more or less, that is figures of, it's double, Italian figures on cancer, or figures on cancer in Italy. And I'll show you some data from the 2020 edition and some from the 2023 edition, because I don't know how, but some data are not in the most recent edition, the 2023. We missed some data. You don't have to read, also because it is in Italian. But the problem about these tables, and I'll show you some others in the following slide, is that in this slide we have gallbladder cancer and biliary tract cancer together. In this slide we have liver cancer and intrahepatic cholangio in one table, biliary in another one, gallbladder and biliary in another one. So I don't know how we can put together the incidence, the prevalence, the mortality, because we collected data, and this is a big effort, but we collected data in a non-homogeneous way. And this is the most important collection of cancer data in Italy, but this is a problem. Moving into more details about the biliary tract cancer, this is the table regarding gallbladder and biliary tract cancer. They are grouped together. And the first line is incidence. And okay, we have the incidence in 2020, 5,400 new diagnoses, but the estimates for 2023 are not available. I don't know why. Mortality estimates for 2023 not available. Survival, 5 year survival estimate for 2023 not available. In 2020, 17% for men and 15% of women. This is for all stages. The probability to live 4 more years after the first year, so meaning the less aggressive cancers, we don't have estimates for 2023, we have for 2020. We have the prevalence, 12,700 people living with biliary tract cancer in Italy. But the problem is related, the problem of missing data is related to gallbladder cancer and biliary tract cancer, because these are the data for liver cancer and pancreatic cancer. You don't have to read it, they are in Italian. But we have all the data. So for some reason, no explanation, we miss some data. And it's probably because the collection of the data is not so good. We have sometimes liver, sometimes cholangio, sometimes biliary, sometimes gallbladder. So it's difficult to put these data in a table. So this is the first issue. Then, this is not an issue, but this is a good thing. This APIC, the Association of Italian Patients with a Cholangiocarcinoma, they started some years ago. They were few people. They are doing a great job. Also, thank Ellen for collaborating and helping them a lot. And the website is very useful for the patients. There are all the centers specialized. Unfortunately, and this is typical in Italy for many things, most of the centers are in the northern part. In the south, you can see there are a few. And for each center, this is mine, so I put mine because it's easier. There are all the different options that are offered to patients, medical oncology, surgery, hepatology, radiology, and so on. In green, in red, we don't have the transplant. We have a connection with the transplant centers. And in the green box, there are the names of the specialists that are involved in the management of patients with biliary tract cancer or cholangiocarcinoma, and also what we can offer outside of clinical practice, meaning clinical trials, biobank, academic research, and so on. And this is very, very helpful for the patients because sometimes when they don't know if there are a good center and expertise, a center with expertise close to where they live, they can ask APIC and they send the patients in the different centers. And also then they have the patients groups and all I hope most of the support that patients need. Now moving to what we can do in clinical practice. This is the ESMO, European Society for Medical Oncology treatment algorithm. And you can see that, in first line, first, for patients with advanced disease, we have to do the molecular profiling. We have discussed this a lot. And then we have treatment with the cisplatin, gemcitabine, durvalumab. Pembrolizumab was not yet approved when these guidelines were published, but they are being updated. So what we can do in first line in Italy. So we published this consensus to clarify what we can do, because not all the options are available in Italy. So starting from the molecular profiling in the first line, molecular profiling is reimbursed by the national health system in Italy in most of the region from the last months of 2023. So 1 year ago, we didn't have the reimbursement. This is kind of a strange thing because we had pemigatinib approved for patients with FGFR2 gene fusions, and that was reimbursed by the national health system, but the test was not reimbursed. That's Italian thing. But anyway, we managed to do that. Now it is reimbursed. However, the national health system is organized based on a regional way and not national. For instance, I live and work in Milan, that is in Lombardy, in the northern part of Italy. And we, the local government established a commission, I was part of that, and we decided that all patients with advanced biliary tract cancer should receive an NGS, and also we decided, based on a survey on the numbers, which are the centers that are allowed to ask for the test and to perform the test, and also we organize how to refer the patients. So this is working very well. But this is one region, so in the country, this, the molecular profiling organization is very heterogeneous. And another point is that each pathology department can decide which is the best test. So if we would like in the future to collect the data, probably we will have again very heterogeneous data. But anyway, we can do that, and this is important. You have already seen this. The cisplatin, gemcitabine, durvalumab is the new standard of care in first line. In Italy, it has been defined the reimbursement in February this year. But we were lucky enough because for 1 year and a half, the pharma company provided durvalumab for free to all the patients. We had to do a request for each patient, but it was a formality, just an online form, and we received the drug. So we were able to treat the patients, and also we decided to collect the data. I've shown this this morning, and the data are very, very similar to the TOPAZ-1 trial. So we were able to reproduce the data in clinical practice. This is always important because patients enroll in clinical trials, especially in phase 3 trials, are very well selected. And we achieved the same results in terms of efficacy, but also in terms of safety. These are the adverse events and the immune-mediated adverse events. And the data are very similar to what has been published for the TOPAZ-1. So again, this is important for the patients because the data are reproducible in clinical practice. And also we are doing some translational work on this, and some already published, but we are still working on this. You know that the second line we have discussed a lot. Second line treatment should be based on, or the treatment should be decided based on the molecular alteration, if present, and up to 45% can have potentially clinically actionable alterations. Okay, and this is, again, a modification of the ESMO guidelines based on what we can do in Italy. Of course, we have chemotherapy for all comers. We have pemigatinib for patients with FGFR2 gene fusions, and I'll show some data. We have an expanded access program for zanidatamab for patients with HER2 amplification, only in expert center, but patients can be referred. And then we have the agnostic approvals for NTRK inhibitors and pembrolizumab for MSI-high patients who did not receive immunotherapy in first line for some reasons. And also, we published a position paper to try to give some practical guidelines about the molecular testing, so which are the pros and cons of the different testing that are available, and a practical guide for molecular testing in biliary tract cancer. Because as I said, for instance, in my region, only expert center can ask for and do the test, but in other regions, all the centers can do. So I think this can be useful for physicians working in less expert center to have some guidelines regarding the test. And this is the kind of algorithm to follow for the test. I've mentioned that we have pemigatinib in Italy reimbursed, and we published in collaboration with French colleagues real-world data. And once again, the data are very similar to what has been published in the phase 2 trial in terms of progression-free survival, overall survival, and also this show that patients who respond do better than patients who do not respond. And this is really important. We mentioned many times that treatment according to the molecular alteration is the best treatment. This is the progression-free survival according to the type of second line of treatment in patients with FGFR2 gene fusions. And these are patients that treated, it's not a randomized, it's just observational data. These are patients treated with pemigatinib, these are patients treated with chemotherapy. So if there is a molecular alteration, we should treat the patient, if available, with the targeted agent, because the outcome is completely different compared to chemotherapy, if there is an actionable alteration. We have heard a lot about ivosidenib, and this is the phase 3 trial. In Italy, the situation has been like a kind of a roller coaster. So we don't have ivosidenib reimbursed yet. In 2021, probably, the government allowed to request the treatment for a single patient with a kind of letter explaining the motivation and so on, and provided the drug for free. And we published the data, but you can see here 8 patients, then we updated the data, 11 patients, then the government decided that the cost was too high and stopped. I'm really transparent, this is what happened. Then the phase 3B, organized by the pharma company, started. This was this year or last year, probably at the end of 2023. We had at my center 10 slots available, so 10 patients we were allowed to treat with ivosidenib in the phase 3B trial, and we completed our slots, I think, in 1 month or 2, because we had so many patients in a waiting list, and as soon as we opened the trial, we treated the patients and then stopped. So now we are again without ivosidenib for patients with IDH1, similar as in other countries. Now, moving back to the initial stage, there is this small study that suggested that a neoadjuvant, we have already talked about that, a neoadjuvant treatment administered before surgery can be useful. This is with a regimen including cisplatin, gemcitabine, and nab-paclitaxel. We know that the phase 3 in the advanced setting was negative, but in patients with locally advanced disease, the triple chemotherapy combination achieved quite good results. And so we started a phase 2/3 randomized trial in the preoperative setting for patients with resectable disease but high-risk features, and they are randomized between a neoadjuvant treatment, surgery, and capecitabine for a shorter period of time because they will receive chemotherapy also before surgery, and the classical, the standard of care surgery followed by capecitabine. This is just started. I think there are 4 patients enrolled, and we will see the results in the near future. This is just to highlight or underline that we have always to discuss. We need to discuss patients in a multidisciplinary team, and also we need to interact different centers because, for instance, I mentioned zanidatamab is available in Italy in some centers, not in all centers, so it's important that patients who have HER2 overexpression or amplification are referred to the centers where the drug is available. So to conclude, what are these? Sorry for the busy slide, but just to summarize. APIC, that is the Italian Patient Association, represents an invaluable resource for patients with cholangiocarcinoma or biliary tract cancer. Molecular profiling is reimbursed now in most of Italian regions, but just in the last months. Some regions define hubs for molecular profiling and establish that NGS is the best treatment, is the best test, so patients have all the potential molecular alterations tested. Chemotherapy is reimbursed in all settings except for Naliri, that is not reimbursed. The standard of care in first line is cisplatin, gemcitabine, and durvalumab. Pembrolizumab is not reimbursed in Italy for this indication. There are ongoing trials, some academic and some industry-sponsored, of targeted agents, immunotherapy and chemotherapy in the different settings, and we try to enroll patients and to make them aware about the clinical trials where they can be enrolled. Issues, just some of them, numbers that are collected in a non-homogeneous way and incomplete way for biliary tract cancer. The reimbursement by AIFA, that is the Italian regulatory agency, it's a long process, approximately 1 year or more after the EMA approval. This is not acceptable, but this is what it is. And again, the multidisciplinary approach is key, but it's not mandatory. So in some centers, patients can be treated without an MDT discussion. It is mandatory only, for instance, in Lombardy, for the NGS. And this, again, is something that is not perfectly working. So this was my last slide. And that was just to highlight that we will be talking more and more about cholangio. In July, there will be the ENSCA plus COST BTC Precision Network meeting in Krakow. And in October, there will be the ILC annual conference in Toronto. And thank you so much for your kind attention.